Well, it's a pleasure to have Dr. Goldsmith today to speak on heart failure. I know Steve for 30 years approximately. I think you did your training at Ohio State, correct? That's just before fellowship. And then he did his fellowship at the University of Minnesota, did a lot of work with Dr. Jay Cohen, and then has been at Hennepin County for many years, did a lot of clinical and basic research there. And he's now director of the heart failure program at Hennepin. He's a professor of medicine at the University of Minnesota. And he's a real expert on heart failure, and we're glad to have him here.
Well, thanks, Adrian. I have spent, this is my 31st year at Hennepin, and a few weeks ago I was giving cardiology grand rounds at Ohio State, where I was a student and resident, and some of my former faculty and mentors were in the front row. And I don't think that they liked to be reminded that it had been 40 years come next summer since I had my first encounters with them, but there they were, and here I am. So, and I have, as Adrian said, I've been very consistent. I've stayed focused on heart failure. The shift this last few years has been more into the acute heart failure space because that's where the need is, quite frankly, right now. It's sobering to remember that although the mortality rate for a stable patient with chronic heart failure, you see a patient in your clinic today who hasn't been admitted in the last year, ejection fraction of 22%, on a stable dose of furosemide and all the neurohormonally based therapies with or without a device, he's got an annualized mortality of between 5 and 6%. When we started the first vasodilator trials in heart failure back in the late 70s with Dr. Cohn, the mortality was 25%. There's no other disease that's had that kind of a drop in mortality, frankly, in cardiology or medicine, to my knowledge, except for a few maybe tumors that have been cured. But that's the good news. The bad news is twofold. One, it's hard to show further improvements in the chronic heart failure space because if your mortality rate's 5 to 6%, you need 20, 25,000 patients, even if you've got something good, to show a further benefit. So this field is kind of stalled out, obviously, except for tweaking VADs and the stuff that you need for the really sick patient at the end of the game, but they're a very small percentage of the total heart failure population. The other bad news is that the mortality and morbidity for acute heart failure hasn't changed at all. And this is one of the big conundrums that we have. As Dr. Giorgiani likes to say, there is no other condition in medicine where you have a patient admitted to the hospital and they're discharged, quote unquote, better and have a 40% mortality and morbidity rate in the next 60 days. There is no other condition even remotely like that. That's acute decompensated heart failure, and we have not been able to make much impact on that. So there's two possibilities. Patients are doomed, and there's nothing we can do. I doubt that very much. I really doubt that very much. They just don't look any different, frankly, if you look at all the things we can measure than the patient that I described first in your clinic. So it really leads to the obvious, to me, conclusion that what we are doing is not working very well. And the things that we have been trying over the last 10 years haven't been working very well. And one definition of insanity is if you keep doing the same thing in the same way and expect a different result, well, there's something wrong with you. So what I'm going to try to do this morning is not discuss the entire field of acute heart failure. Obviously, you can't do that in 45 minutes, but at least talk about one aspect of the syndrome, and that is congestion. And talk about the importance of congestion in the pathophysiology of acute heart failure, talk to you about some of what I think are now becoming more commonly recognized as shortcomings of current decongestive strategies and what might be coming, what is either here now or coming that might be better. And along the way, because this is a very important part of this game, is the cardiorenal syndrome. And that is an area in which our understanding is undergoing a lot of change. And I don't have any definitive answers for you on that, but I will suggest the questions. So let me just begin by reminding you that the reason people get into the hospital with acute heart failure is not because they're in shock, not because they're in hypotensive crisis, it's because they're congested. The congestion, we now believe, has adverse effects on both the heart and the kidney. So it's not just something that happens, it's something that actually becomes an amplifier of the disease process when it occurs. We know that persistent congestion is associated with very poor outcomes in this syndrome, and I'll show you data to support that. As far as the presentation data, what gets people into the hospital is dyspnea, sometimes fatigue, most of them, 2/3 at least, have edema. If you look at the hemodynamics of acute heart failure, though, there aren't very many studies that have done this, but in the studies that have looked at the hemodynamics in this syndrome, most patients are normotensive or hypotensive. Less than 2% are hypotensive. They tend to be mildly or tendency toward tachycardia, even though most of them are on beta blockers now. But if you measure the hemodynamics, they have high filling pressures uniformly because that's the hemodynamic correlate of congestion, the high filling pressure. But they don't usually have anything wrong with their cardiac output. Now, you guys are very in the midst of developing a very aggressive, VAD and transplant program, and I'm aware of that. So the demographics of who gets admitted to your hospital might be a little bit different now than they were a few years ago if you're focusing on this kind of patient. But in the real world, in the broad world of Allina systems in general, an acute decompensated heart failure patient is not going to be somebody who needs a VAD. That's very uncommon. He's just somebody, or she's somebody, that needs to be decongested as the first therapeutic approach. We also know that there is a pre-hospitalization phase, actually, where the pressures will rise. This is from the Chronicle device. So this is indwelling pressure monitor for RV systolic pressure. And this is an example where you see that the filling pressure tends to rise before the patient is admitted to the hospital and then declines as the patient is treated in the hospital. And a very exciting development now with the CardioMEM system is that if you actually know the pulmonary artery diastolic pressure and act on it, you can substantially reduce the admission rate for acute heart failure over a 1-year period of time. This is the CHAMPION trial with the CardioMEMS device. Now, this was in chronic heart failure, mind you, which has a much lower hit rate or event rate, as I just said, than acute decompensated heart failure. And, of course, the people that make this device, the CardioMEMS company, it's been sold to St. Jude for somewhere around $500 million. The FDA did not approve it, interestingly enough, on its first go-around last month. Don't ask me why. But presuming that it is approved at some point, and it should be in my judgment, when you look at the impact of knowing and acting on filling pressures in chronic heart failure, you can imagine what this might do for the acute heart failure space. So let me just put it out there at the beginning. Maybe we just don't know enough about our patients. That's the point of showing the data. Maybe there's something wrong with our therapies. Maybe we need more therapies, or maybe we just need to use the existing therapies more intelligently. So that's certainly a hypothesis that the CHAMPION data suggests. But we do know that if you leave the hospital with predefined congestion, your mortality rate is about double what it is if you leave the hospital in a sufficiently decongested state. And this data comes from the ACTIVE study, which was the run-up study to Everest using tolvaptan or placebo in chronic or in patients with acute decompensated heart failure. But despite knowing that decongestion is important, we don't do it. And this is the old ADHERE data, which everybody knows by now, just pointing out that a really high fraction of patients don't have weight loss or don't have very much weight loss during their hospitalization for acute heart failure. Now, weight loss is not necessarily a great surrogate for decongestion. I think from the standpoint of cardiology for heart failure, decongestion is the filling pressure. That's my hypothesis. But other people argue, no, it's the total body sodium, total body volume. I mean, there's a lot of ways you can measure congestion. But the bottom line is that most of these patients, unless they're just little old ladies with acute diastolic dysfunction where the whole problem is a rise in blood pressure, most of these patients need to have some decongestive therapy, and we're not getting that done. So why is it bad for you? Why might it be bad for you? I mean, the common thinking up to now has just been, oh, well, they ate too many potato chips and missed a couple doses of Lasix, and so, we just put it back to rights. But as I said, the mortality and morbidity data don't suggest that that's true. So there's an emerging body of work that suggests that acute congestion may have adverse cardiac effects. This has not been proven conclusively in my judgment, but when patients are admitted with acute heart failure, they're in a state of neurohormonal storm, even though they may be on the appropriate blocking medications. That increase in systolic and diastolic wall stress that the neurohormonal storm creates can create subendocardial ischemia. And we know that if you have a biomarker, meaning troponin positive admission with acute decompensated heart failure, the outcome is considerably worse than if you have a biomarker negative admission. So that's not proof, but it's a suggestion. That's in patients with normal coronary arteries. So that's a suggestion that something is happening that might be bad for the heart. I think we are on safer ground now in asserting that the congestion has adverse effects on the kidney, because we have been ignoring what has been known in the physiology literature for about 75 years, that increased central venous and renal venous pressure adversely affects GFR. And if you combine an increased central venous pressure with renal arterial or arterial vasoconstriction, you may actually squeeze the kidney to the point that injury is produced, although we don't have any data yet that bear on the actual subtopic of renal injury in acute heart failure. This is a dog study that's from the 1980s, which proves this point. If you simply raise the central venous pressure, holding all other variables constant, the GFR falls, and as you release the central venous pressure, it rises. So assuming the patient's not hypotensive, that's the cardiorenal syndrome right there in most of these patients. It's just a transient increase in the filling pressure, which leads to a transient decrease in the GFR. And if you correct the central venous pressure, you can improve the cardiorenal syndrome, we think. This is a slide that was published a couple of years ago by Mariel Jessup. It's well worth spending time looking at. I'm not going to, in the interest of time, go through it in detail today, but it just makes the point that if you want to understand what's going on in terms of GFR, glomerular filtration, you have to think about the arterial side and the venous side. You've got to think about the input pressure, and you've got to think about the output, the opposing pressure. And this, obviously, if there's hypotension, that's going to drop the filtration fraction substantially. But if you maintain a constant inflow pressure and raise the venous pressure, then you get a drop in the filtration the drop in the GFR. So I am going to be writing a little editorial called Congestive Renal Failure sometime in the next week or two before somebody beats me to it. The concept of congestive heart failure, where we think about preload, ventricular function, and afterload, has served us well forever, you know, in cardiology. And I think there's a precise analogy, except that the preload in heart failure is mainly the venous side, and the afterload is the arterial side. Here they're reversed. The preload for the renal side is the arterial inflow. Then you've got the black box of the renal function itself, and then you've got the afterload, which is the renal venous pressure. So starting to think about congestive renal failure in the context of acute heart failure is something we simply have to do. Because I can tell you, and I don't want to insult any nephrologists who might be present, but if you get a consult for renal insufficiency in somebody with acute heart failure, the usual response is, well, they're intravascularly volume depleted or some such thing. But in fact, central venous pressure is usually very high, the wedge pressure is really high, and what they need is not fluid, they need less fluid. And until you grasp that concept, understanding cardiorenal syndrome is difficult. So hold that thought, because it's not, unfortunately, the whole story. And the other thing you have to think about when treating acute heart failure is that while the cardiorenal syndrome is definitely a problem, it gets in the way of treating these patients, but it is 100% reversible if you do it correctly. We also have renal-cardiac syndromes, because our patients don't just get acute decompensated heart failure, they get it with underlying structural renal disease. And when that happens, you get some unholy mixture of renal-cardiac and cardiorenal, and that is very difficult to treat. And I do think there is probably a group of patients that's pretty much doomed because of that in terms of their kidney. As far as data that support the contention, this comes from Wilson Tang's study from the Cleveland Clinic a couple of years ago, analyzing retrospectively a large group of patients with acute decompensated heart failure at the Cleveland Clinic. they found that the main determinant of GFR was not the cardiac index. None of these patients were hypotensive. It was the central venous pressure. If they had a CVP under 12, they tended to have a preserved GFR. If they had a CVP north of 12, regardless of the cardiac index, they tended to have a worse degree of renal function. So, not proof, but it's certainly suggested data that this is what we're seeing in the patients with this syndrome. So, we have a problem. We have congestion. We're not doing a good job of decongesting the patients. Some of the patients get cardiorenal syndrome. We get renal consults on those patients, and that usually means we back off on the diuretic therapy, or worse, we give them fluid. So we are potentially making the problem worse for some of these patients with acute decompensated heart failure. And how do we treat them? We give them loop diuretics. We give them more loop diuretics. We give them still more loop diuretics. And then we pull the trigger on totally useless therapies, which is adjunctive vasodilators and inotropes. And I mean totally useless, because every study that has been done, except one, has shown that adjunctive vasodilators and inotropes either do not change the course or worsen the course. And that kind of makes sense if you think about the pathophysiology, quite frankly. So what's the problem? What might be the problem? I don't know that there's a problem. I've been writing a lot about this for a number of years, as have others, and I do worry that we've oversold this concept of loop diuretic toxicity, but there are issues. There are issues. Loop diuretics, if you continue to give them, actually work against the production and maintenance of a sustained diuresis because of the braking phenomenon. They unequivocally have an adverse effect on the kidney, acutely via engaging tubulo-glomerular feedback, which creates a transient drop in the GFR, and chronically they stimulate tubular hypertrophy. So when those patients come back to you after a few months on a given dose of furosemide and say, Doc, I am taking my same dose of furosemide, it's just not working, they may not be lying to you. They may be taking it and it isn't working for that reason. Of course, those of us in the neurohormonal community are very concerned that these drugs are stimulants to the neurohormonal systems that our chronic therapy is designed to inhibit. It's like driving with your foot on the brake and the accelerator at the same time. And of course, there is a mortality trial. Many of you may not be aware of this mortality trial. There's a mortality trial of furosemide in heart failure, which didn't copy. We warned us when we changed this format here this morning. This might not be there. Anyway, there is an animal study that showed that furosemide actually worsened the mortality in groups of animals, and it wasn't sudden death. It accelerated the decline in myocardial contractility in the animals that got furosemide. So, you know, if you think about how drugs are developed, the furosemide was introduced in the late 1960s, and things were different in the 1960s. If you have a drug today that you have to study in an animal model and it worsens mortality, what do you suppose the chance of that drug ever getting exposed to a human being would be? Zero. Zero. So I'm not telling you not to use loop diuretics. We haven't got a hell of a lot else for most of our patients. What I am saying is that the data would suggest that we need a better mousetrap. I may have this slide in here after all. Hold on just a second. This is just Steve Gottlieb's classic paper showing that you give furosemide, you get good urine output, but the GFR falls. That's tubulo-glomerular feedback in the first few hours. This is my paper with Dr. Francis that we did back in the early 1980s, a mg per kg of IV furosemide in chronic heart failure, showing norepinephrine goes up, renin goes up, vasopressin goes up, and the consequences of that were an increase in heart rate, an increase in arterial pressure, a decrease in stroke volume, an increase in systemic vascular resistance, an increase in the wedge pressure before they diuresed, and an increase in the right atrial pressure before they diuresed. And it's sobering to realize that the patients never got back to their control cardiac output, even though they got an effective diuresis eventually. So as I said, this is not something that in an ideal world you would synthesize for the treatment of acute heart failure. I do have the mortality trial here. So this was the sheep, and this is the control arm, and that's the active treatment arm, and that's the placebo. You can see there was a fairly abrupt and significant decline in mortality in the animals that were treated with furosemide. Now, that may be blunted if you treat patients with an ACE inhibitor. This study has not been replicated in the presence of ACE inhibition or aldosterone inhibition. The investigators, I think, are working on that. And my guess is that this effect would be attenuated because a lot of it is neurohormonally mediated. But that doesn't get you off the dime or get you off the hook that there is an intrinsic problem with how this drug works from the standpoint of our current understanding of heart failure pathophysiology. That said, as I indicated to you, we have got, for better or for worse, to use loop diuretics. They're the only thing that work quickly, that we can give easily to most patients. And until the DOSE trial was published earlier this year, this is the first trial from the NIH Heart Failure Network, which I think, as you know, we've been one of the regional coordinating centers for, and I think we were in 4th place in final enrollment, which got us on the 2nd line of the paper in the New England Journal. This is the only study that bears on the issue of how to use diuretics in acute decompensated heart failure. And I don't have time to go through the study in any detail, but I do want to make 1 or 2 points that are relevant to this talk. Just briefly, the study was designed to evaluate whether or not it mattered whether you gave bolus or continuous infusion furosemide, and at the same time to determine whether it mattered whether you gave a low intensification, which was 1 times the oral dose, or a high intensification strategy, which was 2.5 times the oral dose. And the endpoints were a combined endpoint of global clinical assessment using a visual analog scale over 72 hours and safety in the change in creatinine from baseline to 72 hours. And most of us predicted that there would be a benefit in the patients given a higher dose of furosemide in terms of clinical findings, but that would come at a substantial penalty in terms of the serum creatinine. And everyone, except Brad and myself, everyone bet that the IV continuous would whoop the bolus and that we would settle this question once and for all, because many people believe in IV continuous furosemide as a theological concept because it had never been studied. Well, for one thing, we definitely, definitively, unequivocally, without any doubt, showed that you do not need to give bolus, or you do not need to give IV continuous furosemide as your first approach to an acute heart failure patient. That doesn't mean you can't go to it if the bolus fails, but the p-value was 0.5. So not even a hint that in terms of efficacy, the continuous was any better than the Q12 bolus. And if you looked at high intensity versus low intensity, though, there was, as expected, a borderline statistical change in terms of the well-being. And had we used dyspnea as the primary endpoint, it would have been a positive trial. Dr. O'Connor, who was the senior author of the trial, likes to remind me that the only reason DOSE is not a positive trial is me, because I was the one that argued and convinced the steering committee not to make dyspnea the primary endpoint, but rather to make global well-being the primary endpoint. There was a good reason for that, obviously, and people agreed. No trial had ever hit a primary endpoint with dyspnea in the last 10 years using dyspnea. So most of us, wasn't just me, obviously, didn't want to sink the trial on dyspnea. We thought that there might be some benefit in the global assessment, but it didn't work, and the dyspnea, as I'll show you as a secondary endpoint, actually did. But you got to meet your primary before you can talk about your secondary. Now, here's the interesting thing. We thought, as I said, that this would come at a substantial penalty to renal function, but it really didn't. This looks big, but it's 0.04 versus 0.08, so trivial changes in the creatinine if you look at the change in the creatinine. So the additional clinical benefit in the high-dose arm did come without a substantial penalty, at least if you looked at raw change in creatinine. The secondary endpoints, there's a million of them. A few of them are here. Again, if you look at the Q12 versus the continuous, you can find no evidence in this trial at all that you need to write for IV continuous furosemide in an acute decompensated heart failure patient. And you know, that should change practice because it's expensive. But there were some secondary endpoints where, again, where the high intensification strategy was different from the low dyspnea. The p-value was 0.04 versus 0.06. Probably if we'd done another 100 patients, they both would have been significant. Weight change, obviously, was greater. Net volume loss was greater. And even though there was no change in the average serum creatinine delta, if you looked at the percentage of patients whose creatinine increased greater than 0.3, it was statistically significantly different. And this is the definition of cardiorenal syndrome that many folks use. So whether or not this was due to greater decongestion or whether it was due to adverse effects of furosemide, we don't know. But there was, again, a borderline p-value. Remember, this is only 300 patients, so it's a relatively small trial that suggested that there was some penalty to pay. But interestingly enough, if you looked at the creatinine in the high group, even though it was a little bit higher before they left the hospital, if you looked at what happened at 60 days, the curves actually crossed. So statin C is a new measure that many people feel is better than creatinine, but it really didn't perform any differently in the study. And here's the important, to me, the most important part other than the IV continuous versus bolus Lasix question. It doesn't matter what you do. At 60 days, you get a horrible outcome. Continuous versus Q12, high versus low. At 60 days, the mortality and morbidity rate was 42%, about 12% mortality, about 30% readmission. So this is arguably the best done study in the acute heart failure space, done without any industry prejudice, done by an NIH-sanctioned group of theoretically good people who know what they're doing in treating acute heart failure, and loop-based diuretic strategies yielded a uniformly poor outcome at 60 days, no matter what you did. So the conclusions from DOSE is that as long as we're using IV Lasix as our basic therapy for decongestion, we don't need to give IV continuous as an initial treatment. We probably should give high dose. It'll make people feel better and decongest more in the early stages. And we'll have to be a little worried about the possibility of increasing the degree of worsening renal function. But interestingly enough, the worsening renal function in the hospital here did not adversely affect the 60-day outcome. So even though there was a little bit more of the cardiorenal syndrome created in the high-dose group, it did not change the outcome. And hold that thought, because I'm going to come back to that with two other observations in the balance of the thought. So, as I said, we give loop diuretics, we give more loop diuretics, and we give even more loop diuretics, and then we pull the trigger on adjunctive therapy, and it doesn't help. Vasodilators, you can give IV nitro if you want. There are no placebo-controlled trials that really have looked at nitrates. The VMAC trial had a nitrate arm, and it wasn't much different than placebo. It was a little bit different than placebo during the controlled phase, but not much. Endothelin antagonists, very potent vasodilators based on antagonizing endothelin, no benefit. Nasiratide was, of course, safe, but had no benefit at all in the ASCEND trial, which was recently completed, even though there was a very transient benefit in the VMAC trial that led to its approval. So in my judgment, there's no role at all for this drug. Adenosine antagonism was the great white hope in terms of preserving the kidney by interfering with the tubuloglomerular feedback mechanism, but it was of no benefit whatsoever. And every study that we've looked at with inotropes has actually worsened the outcome. So adjunctive vasodilators and inotropes at this point are either inadequately studied in the case of nitrates or have been shown to be useless or harmful in the case of inotropes. So what else could we do? Well, there's two approaches that one can consider. One could use a different strategy pharmacologically to remove fluid, or one could use a non-pharmacologic strategy, which would be ultrafiltration. Now, we have a fair amount of data about vasopressin antagonism in the acute and chronic heart failure space, and it's unfortunately, well, it's a mixed bag. You can decide for yourself. It does not change long-term outcomes, but let me show you what happened in the acute trial. People forget that the Everest trial, which was a mortality compendium of trials in acute decompensated heart failure, was designed and operated by the FDA and the European authorities as two concurrent acute heart failure trials. These were identical protocols, but they were separate from a regulatory standpoint, because if you know the minutiae of this, to get a drug approved, you normally have to have two trials that confirm a positive finding. So they very cleverly designed two acute heart failure trials from a regulatory standpoint, and the primary endpoint was agreed upon by the FDA to be a combined endpoint of global well-being or weight loss at discharge. Everest also was a long-term morbidity and mortality trial, and that we all know was negative. And those of us that know the vasopressin field pretty well, as some of you know, I've been studying vasopressin for my entire career. I didn't expect a V2 antagonist to change outcomes long-term, but we might have expected it to do something in the acute space, and it did. If you look at the composite components of the day 7 or discharge endpoint that the FDA approved, the p-value was less than 0.001, and it was driven entirely by a change in weight loss. It didn't change global well-being score, but then nothing else has either, except maybe in the high-dose versus low-dose Lasix trial, as I showed you, where it was borderline. So this was the endpoint that the FDA had agreed to, but they did not give the drug approval. So it's a very interesting story, because tolvaptan is the only drug, and it's not a vasodilator, it's a diuretic agent, other than the serotype that was studied in the setting of acute heart failure, which met the pre-specified primary endpoint, in this case in 2 studies. It's just fascinating to me that nasiratide failed to meet an almost identical endpoint to VMAC in a much larger study, but which one's on the market and still being used and which one was denied? Go figure. The FDA is a strange animal. So as far as tolvaptan in the United States, of course, it is approved for the treatment of delusional hyponatremia, so on-label use of the drug includes the hyponatremia associated with heart failure, but not for heart failure in the United States. But it is very interesting, and in my disclosures, I have been a consultant to Otsuka for a long time. It's approved in Asia, and there's a lot more patients with heart failure in Asia than there are in the United States. So it's interesting that the data, that the drug actually is being used with regulatory approval in Japan and will be soon in Korea and China. So the question then always comes up, are we done with vasopressin antagonists? And I certainly hope not, although I'm very prejudiced about this since I've studied it for a long time. It's obvious that you can produce additional weight loss if you add tolvaptan to furosemide. That does not change the long-term outcome in a broad run of patients. But what about using this therapy perhaps in targeted patients? Well, this is where I think you're going to see more research. If you look at the last issue of the Journal of Cardiac Failure, you'll see this paper by Udelson and Company that shows that you can actually, over a week's period of time, get equivalent weight loss with tolvaptan as you can with furosemide. And that's important because all the studies with the Vaptans have been add-on studies, not substitution studies. And in the same journal, we have a paper that looks at the renal effects of conivaptan and furosemide and the combination in stable chronic heart failure patients. And the bottom line from this study is that we could leverage conivaptan to almost double the sodium excretion produced by a given dose of furosemide. So if you think that high-dose furosemide can be problematic from a neurohormonal standpoint, it's possible that one could design a trial using conivaptan and low-dose furosemide or tolvaptan and low-dose furosemide. So if you want to read more about this, again, in the same issue, I would read this editorial by John Burnett. Everything John Burnett writes, in my judgment, is worth reading. And he actually goes through the whole story here about where the Vaptans might fit in as either alternative or Lasix-sparing agents. Remember, everything we know is add-on to full-dose furosemide. So if furosemide is part of the problem, maybe we need to do something different. So unfortunately, well, it's rational, but Otsuka is not going to be studying this in the United States or Europe in any major way, but there are a number of investigator-initiated studies which are underway, including one we've designed, that will give us more insight into this. But it's worth remembering that if, in terms of a drug that causes a lot of urine to come out, this is the only class of drugs you've got. And I was at a meeting last month in Dusseldorf where of chronic, there's a new balanced B1A, V2 antagonist that's been synthesized by Bayer Pharmaceuticals, and they are committed to a heart failure program. So I was there helping them design their phase 2 program. So I don't think we've seen the end of vasopressin antagonists, but I think right now it's strictly an off-label use. to use the drug from the standpoint of heart failure, tolvaptan or conivaptan, but we would like to think that new research might change this in the next 5 years. So that brings us to the non-pharmacologic alternative, and here, of course, we do have outcomes data that are very exciting, and that is with the use of ultrafiltration. And ultrafiltration directly removes isotonic fluid, and it removes more sodium than loop diuretics, which create an isotonic, so at most diuresis, hypotonic diuresis, I'm sorry. And from the standpoint of all the bad stuff that we can get with furosemide, it doesn't happen because ultrafiltration bypasses the kidneys. It doesn't create any electrolyte disturbance. It doesn't activate the neurohormones. It has no adverse effect on hemodynamics. And if you go back to a paper done by the Italian group led by Agostoni back in 1994, this was a study in chronic heart failure patients that were admitted to the hospital and given a single run of ultrafiltration or an equivalent decongestion with furosemide. And so with identical weight loss, the patients were then sent home on the same dose of furosemide that they came into the hospital on. And the patients that got the ultrafiltration tended to have a preserved weight loss, whereas at 3 months the patients with the furosemide had an increase in their weight. And there was no additional, if anything less, furosemide given to this group. And this study incorporated acute and recurrent heart catheterization as well, and so you saw with very equivalent drops in the right atrial and the wedge pressure, again, as they would parallel, as you might guess, the body weight, so that at 3 months they were back at or above control values in the furosemide group, and they stayed low in the group that was given ultrafiltration. Very interesting observation, lots of possible mechanisms. Lots of possible mechanisms. Maybe you just took out more salt, so it took longer to re-equilibrate. Maybe it was the transient difference in the neurohormonal activation, which was fairly profound in the two arms. Nobody knows. Nobody knows, and there are studies which have been proposed to try to figure that out. But knowing that it was safe and knowing that we had a technique that could do ultrafiltration without engaging the whole renal apparatus with CBVH, and that was the CHF Solutions device, that's how our consortium got started, because in the early part of the last decade, as we were trying to get this heart failure consortium together, we needed a trial. And CHF Solutions, which is based up here in Brooklyn Park, they initially thought that people would just flock to this device without any data. But after about a year of not selling any devices, it was really kind of a wonderful coincidence. They came and met with me and Brad at the same time as we're trying to think of a study to get this consortium off the ground, and so that's what happened. We did the RAPID trial, which was the first actual clinical trial of ultrafiltration in acute decompensated heart failure, and it did show that in a small study, 40 patients all done here in the Twin Cities, that you could beat usual care with ultrafiltration in the setting of acute heart failure and do it safely. And you'll notice, because the weakness of all ultrafiltration trials is that you can't blind them, we did not want to game the system in favor of the ultrafiltration, so we asked the investigators to be very aggressive, and look what happened with usual care. That's a 5-liter volume removal at 48 hours. That's way better than in any other trial that's been studied in acute heart failure, including dose up to now. So we were able to show safely that you could beat even a very aggressive diuretic-based diuresis. And then that, of course, led to the UNLOAD trial, and the UNLOAD trial was basically the RAPID trial, but with 4 times as many patients in it. And that showed that the primary endpoint, in this case weight loss, was met. And if you looked at the weight loss of 5 kilos in the ultrafiltration arm versus 3 kilos in the standard of care arm, it's roughly in conformity with the volume loss numbers we had in RAPID. Dyspnea was not better, again showing that dyspnea is, despite a really significant difference in volume removal, dyspnea is a difficult endpoint to meet. But of course, the outcome that got people really interested were the pre-specified secondaries. So this was not a retrospective analysis. It was not a post hoc analysis. These were pre-specified secondary endpoints, totally fair, despite what you read in some quarters, to analyze these because the primary endpoint of weight loss was met. Remember the rules, the statistics and studies. You meet your primary, you get to analyze your secondary. It's fair. So, patients rehospitalized, rehospitalizations per patient, number of rehospitalization days per patient, no matter how you want to slice this, there was a significant difference between ultrafiltration and diuretic-based decongestive strategies. And that, of course, is why many of us feel that either ultrafiltration itself or a pharmacologic cocktail that looks like ultrafiltration should be studied further, because we know that keeping people out of the hospital is critically important financially right now. And if you have larger numbers of patients, maybe more effective decongestion could actually have an impact on mortality. We don't know the answer to that question, but those trials need to be done. What is going to happen, though, is a larger trial of ultrafiltration, which I'm sure you'll be asked to participate in. Certainly if we get to interface it through the consortium, you will, but they may or may not deal with the consortium, and I'm sure Dave will be interested in this. It's called AVOID, and it will be basically unload, but with 3 times more patients, and the primary endpoint, not the secondary, the primary endpoint will be this, a metric like this of utilization. Because obviously, even though it's more expensive and somewhat cumbersome to do ultrafiltration, it's not something you can do in everybody. It's got issues around anticoagulation. You have to have a decent vein. I mean, it works great when it works great, but when it doesn't work great, it doesn't work great. And before you pull the trigger on something that is expensive too, you need to show that this kind of a benefit would be replicated. But obviously, it wouldn't take much of this to offset the cost. That's for sure. So stay tuned. Now, I want to spend the rest of the talk just on a couple more items about cardiorenal syndrome, because it's getting more interesting. I mean, it's clear that congestion can drive cardiorenal syndrome, but it's not quite that simple. And if you look at the CARES trial, or look at the UNLOAD trial rather, in terms of the change in the creatinine, one of the reasons people were nervous about UNLOAD was this. There was a substantial increase in the serum creatinine at discharge in the patients that got ultrafiltration, okay? But it didn't persist at 90 days. It didn't persist at 90 days. That looks a lot like the high dose versus low dose data. There was more cardiorenal syndrome at discharge, but it went away at 90 days. And the outcomes were not different in the dose trial, as I showed you. In UNLOAD, they were better, despite this transient rise in the creatinine. So this transient rise in the creatinine is probably a different kind of renal insufficiency than that associated with congestion, because it occurs with vigorous decongestion, right? And then along comes this paper. Oops. You see how things get dumped when you go back? Where's Ashley between these formats? Very interesting. I don't know what happened to the cover for that. But anyway, this is the Testani analysis that was published about a year and a half ago in Circulation. So I'm sorry the abstract didn't reproduce here. What you're looking at are the survival curves in the ESCAPE trial. Now, the ESCAPE trial was a large trial that looked at hemodynamically guided acute heart failure management versus non-hemodynamically guided management. And it showed that the routine use of the SWAN didn't change the outcome. But whenever you've got 500 patients carefully studied and a lot of data, you can learn things. So what these investigators did was they looked at the entire ESCAPE population, and they looked at what happened to mortality, in this case survival, as a function of whether the patients hemoconcentrated or not. And as you can see, the patients that hemoconcentrated, as shown by an increase in the creatinine and certain proteins that they had measured, the mortality was substantially better than the patients that did not hemoconcentrate. Again, making a pretty strong argument that if you successfully decongest patients, however you do it, in acute decompensated heart failure, they do better than if you do not. Well, what was the price of the hemoconcentration? The price was an increase in the GFR. while the patients were in the hospital. So the GFR actually went up in the group that didn't hemoconcentrate, and it went down in the group that did hemoconcentrate, and yet, despite that, the outcomes were much, much better in the group that did hemoconcentrate. So now it's getting really confusing, isn't it? Because we have to look at another arrow when we look at cardiorenal syndrome. In addition to thinking about pathophysiology and what happens to the creatinine in the hospital, we have to think about what happens to the creatinine after they leave the hospital and what the impact of that change in creatinine is. And I think there may be a slide that says that, well, I'll just say it now, it's later too. The bottom line is that all changes in creatinine are not created equal, pretty clearly. If you drive the serum creatinine up and it keeps going up and up and up and the patient gets on dialysis, that's not so good. But a transient rise, and you don't know that until the patient comes back, unfortunately, but if the rise in the creatinine is accompanied by an aggressive decongestion, the evidence would suggest at this point that they actually do better, not worse. Now, that's another study that needs to be done, prospective study of really aggressive to the point of renal insufficiency, perhaps, versus not. But it's definitely muddied the water, but in a good way, I think, because it comes back to the fundamental point that decongestion is your most important item in dealing with acute heart failure. And if you successfully decongest the patient, they'll do better, even if the kidney function deteriorates a little bit while you're doing that. Okay, so this brings us to a couple last comments about where ultrafiltration might fit in here, because we are going to have data very soon. We have long thought that ultrafiltration, based on everything we know, would be perfect for the cardiorenal syndrome because it rapidly removes volume and lowers the central venous pressure and does not stimulate neural hormones or cause any afferent vasoconstriction in the kidney so far as we know. And therefore, we would think that it would be very effective in congested patients who develop renal insufficiency. Had we known what we know now, we might have designed CARES a little bit differently, but that's the way it is. And so the CARES heart failure trial, which is another trial from the NHLBI Heart Failure Network, and Dr. Bart and I are the co-principal investigators for CARES heart failure. We have 186 patients enrolled, 14 patients to go as of yesterday, or as of today. So hopefully I will be back here, or Brad will be back here in the next year sometime going over the results of this trial, because whatever happens with CARES, we are going to learn some very important things. If ultrafiltration wins, that's going to create a very definite niche use for this technique. If it's not better than a stepped care approach, then we're going to have to figure out why it was not different. But this is the, oh, that did reproduce either. So anyway, I'll just skip that part and just summarize then by saying that congestion is the primary therapeutic target in heart failure. I think this is borne out by a lot of lines of evidence right now, including the outcomes data that we have from several randomized controlled trials. We do suggest, the data do suggest that until we learn more at any rate, an aggressive decongestion is better than a less aggressive decongestion, even if the renal function transiently worsens. The diuretic-based strategies, it's unequivocal, whatever you think about loop diuretics, they have yielded uniformly poor outcomes in this syndrome. And that ultrafiltration is a theoretically attractive and clinically proven alternative to diuretics in acute heart failure when significant volume loss is needed. Where do I think this needs to go? Well, one thing for sure is we need to identify safe versus unsafe changes in renal function. And there's a lot of interest right now in renal injury biomarkers. If we could identify what kind of renal change, what kind of GFR change was actually associated with renal injury, that's probably not something you want. But at this point in time, this is very exploratory. What is the best way to assess decongestive efficacy? You know, I've been in meetings where we spent 3 days, and there's no agreement on this. Personally, I do think it's the cardiac filling pressure, if thinking about it from a heart standpoint. But the filling pressure, you're not measuring it continuously either, unless you have an implanted device, and the results from the CardioMEMS device are very exciting, that maybe if we just know the filling pressure, we can do a lot better.
This business about the transient renal function occurring in the face of aggressive decongestion but without a low blood pressure, that's very interesting. What is the signal for this transiently worsening renal function despite improving but persistent congestion? It's not the central venous pressure. It's not the arterial pressure. It's not the cardiac output in all probability. So we're not quite sure what that signal is, but it's interesting to speculate because if we knew what it was, maybe we could modulate it. And from the standpoint of clinical trial design, was the beneficial effect of ultrafiltration and unload related to a greater degree of decongestion or specific to the treatment choice? And our application for renewal in the Heart Failure Network was unfortunately turned down, and our protocol was based on exactly this. The study is called Conquer Acute Heart Failure, and we're going to have to find some way to get that study done, but not in the NIH context. And then lastly, and this is where a lot of us are focusing our attention right now, and it's kind of nice because the Mayo Clinic with Burnett's team is very interested in this as well. What we are interested in with the Mayo group is the question of whether we can produce what I would call a more renally responsible diuresis with new pharmacologic approaches. Because it's actually possible to produce a sodium and water diuresis by combining a natriuretic peptide and a vaptan that produces comparable salt and water loss to furosemide and does not engage the neurohormones. If anything, you have an inhibitory effect on the neurohormones. So to the extent that the choice of therapy and not the amount of therapy with loop-based diuretics is influencing these poor outcomes, the signal we get from unload on the one hand is do a lot of diuresis or decongestion, but on the other hand, do it in a way that doesn't stimulate the neurohormonal axis. Well, there are ways to do that pharmacologically, and in the end, being pharmacologically oriented myself, what I'd like to see is that 10 years from now we have a pharmacologic cocktail, not a device, that cheaply, easily, and effectively produces decongestion compared to loop diuretics. And Don Burnett and I are both either 60 or in our early 60s. We're both healthy. Neither of us intends to resign anytime soon or retire. And we both set this as one of our goals, to do everything we can so that maybe 10 or 15 years from now, one of us could be giving lectures like this, and the response in the audience will be, wow, we were using that LASIK stuff. That was really a problem. And, you know, that's the way medicine moves on. You know, you learn what works, you learn what doesn't work, and then you change. But I think at a minimum, no one should be complacent with our current strategies for treating acute heart failure. And while I'm only talking about therapies today based on decongestion, the whole disease management is another issue, but we just have to do something different if we're going to get better outcomes. That is for sure. And I think if we don't, we're going to get whacked by the government, even though the government has no idea how to make it better either. So I'll stop there. It's 8:01. I have to be in clinic with Dr. Campbell at 8:30, but I'd be happy to take questions if there are some in the audience. Thank you again for your attention. Yes, sir. Well, that's, you know, it's really true. In one of my other lectures, you know, I have a picture of from the 15th century woodcut about phlebotomy. It's actually in Osler's first textbook, you know, that phlebotomy is used. Well, I think that's what ultrafiltration is. Except you're not taking the red cells out, and you don't want to deplete the hemoglobin either. That's the problem. So, but yeah, a randomized controlled trial of phlebotomy or rotating tourniquets might be very interesting compared to loop diuretics in the acute phase. Yep.
From the standpoint of a non-heart failure cardiologist, then you give missing information on really extent as renal function well. Well, creatinine is not good. Creatinine clearance has differential standpoint. Is there a better way, or what should we be thinking of? What should be a better way to assess renal function other than this renal injury?
Right.
Component of looking for the clinician sitting on the floor.
Yeah. Well, at this point, well, for one thing, BUN is probably better than creatinine because one of the problems with creatinine, these acute changes, is that creatinine is co-transported with furosemide. So you get some bump in the creatinine just because you're giving furosemide. And if the BUN is going up, that is a marker for renal vasoconstriction, basically. So personally, I look, if the creatinine is going up a little bit, the BUN isn't, I don't worry too much about it. But if the BUN is going up a lot, then I think that's probably a more sensitive marker, and the ADHERE data cart would suggest that. It may actually be a more sensitive than creatinine for poor outcomes in acute decompensated heart failure. So I would, the reason I focus on creatinine here is that's what's in the literature, of course, for cardiorenal syndrome, rightly or wrongly. But there are no new biomarkers that you can use. The renal injury stuff is just in its infancy. My own bias is that we're not going to find a lot of renal injury. I think that this is mostly hemodynamic, okay? And so we are going to be paying more attention to the BUN for sure. And actually in dose, we haven't looked at the BUN data. That's going to be a whole separate paper as whether BUN performed any differently, you know, than creatinine. So I would say look at the BUN carefully. Don't worry about small changes in creatinine. And
so the rise of creatinine then is the renal failure to the degree of,
well, I think
when you start to work.
Yeah, I think that what we've been teaching for many, many years is probably correct. You know, you should give them enough diuretic or enough ultrafiltration so the creatinine starts to go up a little bit, then back off. But if it comes back down and they're still congested, don't stop and send them home. You might need to work a little bit harder because whatever the signal is, we've observed this, and I'm sure you guys have too, many times. When you drop the ultrafiltration rate from 300 cc's, say, to 200, the patient still got a high central venous pressure, but the creatinine that went up a little bit comes back down. So we think the signal relates, the kidney somehow is perceiving the shift from the extracellular to the intracellular space. It's called the plasma refill rate. And it's a more subtle finding than the gross central venous pressure or arterial pressure. But somehow the kidney is sensing where the fluid is in the vasculature, because that's what's happening for sure. I think, you know, you're just exceeding the rate at which the fluid is being processed out of the third space into the vasculature and out by the kidney. So somehow the kidney senses that. So when you see it, I still think you back off, but you don't necessarily stop. That's a time to look at the patient. You know, if you don't have a central venous pressure in and you lie in and you can't read the neck veins, we do a lot of bedside limited echoes for this, because if the IVC is still 2.5 centimeters with decreased respiratory motion, they still need more diuresis for sure. But if it's down to 1 centimeter, you know, and doing this, okay, that's enough. So I think we do have to individualize. All I can really say is based on what we know, it's not necessarily a bad thing, but we better individualize our approach. Yep. Thank you. No, it was way too small. It was 160 patients. Yeah. And well, yeah, but even a void will be too small for mortality. You know, because the mortality is 10%, you still need, I think that the arithmetic is, you know, you need a couple thousand patients at least in each arm, and nobody has the money to do that, or the company doesn't have the money to do that.
Gold standard is good off, and they're dying at 2 months. What about short-term valves?
Well, that's exactly, I mean, if you take the point that ultrafiltration, you know, intermittent ultrafiltration, you don't need dialysis if the creatinine is stable, but intermittent ultrafiltration has been suggested. In fact, that was a study we proposed to the NIH 5 years ago, that we take one group of patients, decongest them with diuretics, another group decongest them with UF, and only use UF in the outpatient realm, and, you know, with intermittent, because again, if you're hammering them with a drug that might not be so good for them, then maybe just intermittent use of diuretics or intermittent use of ultrafiltration would be better. I mean, you can see how the trials that need to be done, there are at least a dozen good studies that need to be done right now in this space. And it's not that we don't know what the questions are. Problem is, there's no industry support for this kind of thing right now, other than Gambro for UF. And the NIH, well, you know, it spends $1 billion less on heart and vascular disease than it spends on cancer, even though it's still the biggest killer. So it's just really difficult to get funding to do these trials. It's very frustrating because that, I think, is a very important observation, and we need to study it. But it's just anecdotes at this point. All right. Well, thanks for coming.